So for the next session, which is Oncology, Drugs and Acute Kidney Injury, I'd first like to invite the panelists, Dr. Urmila Anand from Delhi, Dr. Edwin Fernando from Chennai, Dr. Bhavesh Vora and Dr. Alex Suratkal sir on stage. Dr. Shruti Gupta has sent a pre-recorded talk. She is from Harvard, Boston. She's the director of Onconephrology program, and her clinical focus is on onconephrology and research focus is on nephrotoxicity of cancer therapies. The questions will be taken by the panelist.
I don't think we'll have time for question answers.
At Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, Massachusetts. I'm so excited to be giving this talk to you today on onconephrology. This is such a rapidly growing field, and nephrologists all over the world are soon going to be charged with facing increasingly complex patients with cancer. Here are my disclosures. All right, so my objective today is to present 3 cases. One case is going to be AKI related to the cancer itself. One is going to be related to the treatment, and one form of AKI can be seen with both cancer and its treatment. So let's delve right into the first case. So this is a 76-year-old female who presents with bilateral lower extremity edema, hypertension, acute kidney injury, and 9 grams of proteinuria. Her serum creatinine was elevated to 2.3 milligrams per deciliter from a prior baseline of 0.8 milligrams per deciliter. Her SPEP with immunofixation is negative for an M spike, but her capital lambda ratio is notably low at 0.01. So my next step here was to get a kidney biopsy, and it showed the following. You can see this amorphous pink material in the mesangium and peripheral capillary walls. This is a Congo red stain that shows orange-colored positivity by regular microscopy. And if you looked at this under polarized light, you'd see this apple green birefringence. On immunofluorescence, you see positive stains for immunoglobulin. And also on immunofluorescence, you can see that lambda clearly stains brighter than kappa. On electron microscopy, you have evidence of these fibrils that have deposited in the kidney, and these fibrils are organized and they range in size from 8 to 10 nanometers. So what is the diagnosis here? This is a case of AL amyloidosis. So what is amyloidosis in general? So amyloidosis involves the misfolding of soluble precursor proteins that form these amyloid cross fibrils that then deposit in tissues and cause organ injury. The amyloid deposits, as you saw, are Congo red positive and have this characteristic green birefringence under polarized light. At least 31 amyloid precursor proteins have been identified. And while amyloidosis, cardiac and renal involvement are by far the most common. Now, amyloidosis is very much a systemic disease. And as I mentioned, the heart is the most commonly affected organ, but the kidney is really not far behind. And patients, when they do have kidney involvement, they usually present with nephrotic syndrome. Although occasionally, if they have more vascular involvement than glomerular involvement, they may not, and the predominant manifestation may be AKI. Also, patients can have involvement of other organs, like they can have liver involvement, GI involvement, they can have macroglossia, and dysfunction of both the peripheral and autonomic nervous system. The graph here in the upper corner shows that patients with AL amyloidosis have much better renal survival and overall survival since the advent of both clone-directed therapy and an increase in the number of transplants that are being performed. When you are faced with a patient like this, you want to work them up by sending an SPEP with immunofixation. An SPEP will tell you the quantity of an M protein, and then the immunofixation will be able to characterize that M protein further and help subtype it. Serum-free light chain is by far the most sensitive test, and so you always want to send that as well. And the combination of these tests, the sensitivity is essentially 100% for myeloma and Waldenstrom's and 97% in AL amyloidosis. Especially in a patient with suspected AL amyloidosis, you're also going to want to send a 24-hour urine protein electrophoresis. A spot UPAP has essentially little to no utility, so you want to make sure it's a 24-hour collection. Now, you always need to confirm the diagnosis with doses. It's reasonable to start with a bone marrow biopsy and a fat pad biopsy, and together that will help identify around 85% of cases. But if these are negative and you're concerned that the patient may have a so-called monoclonal gammopathy of renal significance, then you want to proceed to a kidney biopsy, which is what I did here. It's also important to consider the importance of mass spectroscopy. And the reason for that is accurate subtyping is critical. So there are numerous subtypes of amyloidosis, and it's important to remember that 10% of systemic amyloidosis is genetic or hereditary. And so an important mantra to remember is that having abnormal serum free light chains, having MGUS, and having a bone marrow and renal biopsy showing amyloid doesn't mean that all of these things are related. And in fact, you can have an unrelated MGUS that can coexist with a hereditary amyloidosis. And there's this fascinating case of a patient that's actually published in the New England Journal many years ago. This patient had wild-type transthyretin amyloidosis and a concomitant unrelated MGUS and was misdiagnosed as having AL amyloidosis. And as you can imagine, that has major treatment implications for the patient. And how do you do subtyping? Well, without getting into the nitty-gritty of this, basically you do tissue sampling by laser microdissection, and then you do this tandem mass spectroscopy based on proteomics analysis. This technique is able to identify pretty much all types of amyloid, including some of the rarer subtypes. But unfortunately, it's not widely available, and even we at the Brigham, we have to send out our tissue elsewhere. Now, our patient was indeed confirmed by mass spectroscopy to have AL amyloidosis, which is the most common type of immunoglobulin-associated amyloidosis. So how do we actually treat and manage these patients? Well, the first thing that we do for our patients when they're diagnosed with AL amyloidosis is we want to assess their eligibility for transplant, which is based on their age, their troponin levels, their performance status, and their creatinine clearance. If they're deemed eligible, then they're usually induced with bortezomib, and then they undergo autologous stem cell transplant with melphalan conditioning. If they're not deemed eligible, then they're usually just treated directly with a bortezomib-based regimen. And you can see here that regardless of whether they get transplanted or not, hematologic response is assessed based on the reduction in light chain levels. Now, cardiac involvement is one of the biggest predictors of overall survival, and that's based on NT-BNP and troponin levels. Renal response is also super important, and it's based on improvements in proteinuria and GFR. And these are also the best predictors of risk of progression to end-stage kidney disease. And so not surprisingly, patients with higher eGFRs and lower amounts of proteinuria are much less likely to progress to end-stage kidney disease. Now, one thing I want to highlight is that AL amyloidosis is an example of a monoclonal gammopathy of renal significance. And these MGRS lesions encompass a very wide spectrum of renal pathology, as you can see here. And it includes lesions like monoclonal immunoglobulin deposition disease, proliferative GN with monoclonal immunoglobulin deposits, or so-called PGN-MID, C3GN, and more. The key is that MGRS differs from MGUS because the kidney is involved, and they otherwise don't meet hematologic criteria for treatment. This is increasingly being recognized as super important in both the nephrology and oncology world, because these patients, if they're left untreated, they have a very high risk of progressive kidney disease and progression to end-stage kidney disease. And these lesions can also recur post-transplant. And so that's why it's becoming important for us to work with our hem-onc colleagues to identify these patients early and treat them aggressively. Okay, so let's segue to case number 2. So we have a 63-year-old female that I saw in clinic a couple months ago. She's got adenocarcinoma of the lung with metastases to the brain, lymph nodes, and bone. And she's on treatment with pembrolizumab, an immune checkpoint inhibitor, and pemetrexed maintenance therapy. And she came to my clinic for evaluation and management of AKI. She had previously been on triplet therapy with carboplatin, pemetrexed, and pembro, and then she was transitioned to pemetrexed and pembro maintenance therapy. And her serum creatinine had unfortunately risen from a baseline of 0.7 prior to starting all therapy up to 1.4. Her urinalysis was notably negative for blood, protein, any sort of abnormal cells. She did admit to taking ibuprofen regularly. She notably did not have any extrarenal immune-related adverse events, and she was not on a proton pump inhibitor. And we'll talk about why this is important in a moment. So which of the following do you expect to see on biopsy? ATIN from the pembro, tubular injury from the pemetrexed, or acute tubular injury from the carboplatin? This is a little bit of a trick question because the answer could also be A, B, or C, but we'll come back to the quote-unquote answer in a moment. But first, let's talk a little bit about the data for treatment of patients with metastatic non-squamous non-small cell lung cancer, because it's really evolving a lot. And the addition of this immune checkpoint inhibitor, pembrolizumab, to standard pemetrexed and platinum-based chemotherapy has really improved survival in these patients. The problem for us nephrologists is that each drug in this triplet therapy combination has nephrotoxic potential. And in this Keynote 189 trial that you can see here, they compared pemetrexed and a platinum-based agent with versus without pembrolizumab in patients with non-small cell lung cancer. And not surprisingly, AKI occurred more commonly in the triplet therapy group. So let's talk about these agents individually. So pemetrexed has been around for a while. It's an antifolate agent. It's actually derived from methotrexate, and it's used for cancers like non-small cell lung cancer and mesothelioma. It inhibits enzymes that are involved in purine and pyrimidine synthesis, and so it blocks DNA and RNA synthesis that's needed for cell growth. There's a wide spectrum of nephrotoxicity, and patients can get ATN, interstitial fibrosis, nephrogenic DI, distal renal tubular acidosis. Some of the known risk factors for nephrotoxicity are higher cumulative dose and prolonged exposure. Unfortunately, the kidney impairment is not always reversible, and some patients have progressive CKD. Here are some biopsy specimens from patients with pemetrexed nephrotoxicity, and you can see the tubular atrophy as depicted by the white arrow, and then there's chronic interstitial inflammation pointed out by the black arrow. And then the bottom panel shows that these patients can actually have progressive interstitial fibrosis as well. I probably don't need to tell you all about the nephrotoxicity of statins. And despite efforts to find less toxic but equally effective alternatives since cisplatin was introduced over 50 years ago, these therapies are actually still very much used for bladder cancer, non-small cell lung cancer, mesothelioma, head and neck cancer, and much more. AKI is arguably the most serious toxicity caused by cisplatin in particular, and it can occur in up to a third of patients. And it's a big deal because it can jeopardize eligibility for other treatments and predispose to toxicities from other chemotherapies. And when it occurs, the AKI predominantly manifests as proximal tubular injury with ATN. Now, the mechanism of cisplatin-induced AKI has been studied for years and years, and it's multifactorial, probably consists of inflammation, vascular injury, oxidative stress, direct toxicity from reactive oxygen species. And interestingly, there are some data from preclinical models that suggest that magnesium, mannitol, metformin, statins, and some other drugs may reduce the risk of cisplatin-associated AKI. And I mention this because this is one of my prime areas of study. I'm going to be actually looking at some of the mechanisms to reduce nephrotoxicity from cisplatin, so more to come. Now, our patient was receiving carboplatin, not cisplatin. And carboplatin is structurally related to cisplatin, but it's better tolerated and has lower rates of AKI. And though it has inferior efficacy in some cancers, it actually has comparable efficacy to cisplatin in advanced non-small cell lung cancer. Now, I'm not going to go into a ton of detail about immune checkpoint inhibitor-associated AKI because it's beyond the scope of the talk, but this is one of my areas of interest. I could talk about it for hours. Immunotherapy is predominantly associated with acute tubular interstitial nephritis. The AKI occurs at a median of 16 weeks, and we actually identified some key risk factors for immunotherapy AKI, including having lower baseline EGFR prior to starting therapy, concomitant or prior PPI use, and prior or concomitant extrarenal immune-related adverse events, referring to inflammation in other organs like hepatitis or colitis, thyroiditis, among others. Now, one interesting thing to note, our patient did not have any of these risk factors, and her urinalysis and her urine sediment were completely bland. So I know I have you on the edge of your seat now, and so let's come back to our case and think about what could be going on. And what would you do? So the only way to really figure out what's going on in a case like this is to get tissue. So tissue is the issue. And without tissue, it's really impossible to figure out what's going on. So that's what I did. I got a kidney biopsy. And this is a low power view of the biopsy specimen. The top is a PAS stain, the middle is a silver stain, and the lower is an H&E stain. And you can basically see here that there's just mild to moderate chronic changes in the parenchyma. You go closer up, and on this PAS stain, you see flattened tubules. You see tubular epithelial loss of the brush borders. And there's also a focus of interstitial inflammation that's surrounding these non-atrophied tubules. On higher power H&E stain, you actually see the interstitial infiltrates more close up. And you see a lot of mononuclear lymphocytes, and the arrow here is pointing out a rare eosinophil. And so the final diagnosis here was acute tubular interstitial nephritis, likely from the pembrolizumab. So coming back to our question, while the answer in this case was likely A, acute tubular interstitial nephritis from the pembro, the reality is that you can see A, B, or C, and in some cases you may see A, B, and C if there's cumulative nephrotoxicity from all of the drugs. And this case just highlights some of the difficulties that we encounter when we're taking care of patients with cancer who have multiple nephrotoxic agents on board. So with the findings from the KEYNOTE trial that I mentioned earlier and the fact that these patients are increasingly receiving triplet therapy, that actually led us to study AKI severity and recovery among patients who are getting triplet therapy versus those patients who are not. And we actually looked at this in 2 cohorts. And we actually found in 2 separate cohorts that AKI was not more severe in patients who were getting combination therapy versus monotherapy, and that the renal recovery was also equivalent. Now, our data has limitations. These were observational studies, and so there could be some unmeasured confounding, but these data were a little bit surprising and maybe a little bit reassuring that maybe the triplet therapy patients don't do worse. All right, so let's delve into our final case, which is a 52-year-old man with relapsed AML. He's got a white count of 129,000 with 74% blasts, and he's admitted for treatment with venetoclax, a BCL2 inhibitor. One day after he starts treatment, his creatinine rises from 1.1 to 3.2 milligrams per deciliter. On exam, he is tachycardic and he appears ill. His labs are notable for a profound metabolic acidosis, this AKI, hypocalcemia, hyperphosphatemia, hyperuricemia, this profound leukocytosis, thrombocytopenia, anemia, and a very high LDH. So this is a classic case of tumor lysis syndrome, which all nephrologists should be aware of. So TLS is a constellation of clinical and lab findings that results from the rapid release of intracellular contents from dying cancer cells. And this includes hyperuricemia, because uric acid is actually metabolized from xanthine, which is a byproduct of DNA and is released during cell breakdown. With lung depletion actually leads to AKI. And as you can see here, AKI is just one complication of TLS, but some of these patients can also develop life-threatening arrhythmias from the hyperkalemia. They can develop volume overload, leading to respiratory failure. And so this is truly considered an oncologic emergency. Now, the Cairo-Bishop definition for TLS was proposed in 2004, and it helped provide specific laboratory criteria for diagnosing TLS both at presentation and after treatment. And laboratory TLS is defined as any 2 or more of normal serum values that are present within 3 days before or 7 days after starting chemotherapy. Clinical TLS is defined as having laboratory TLS and then any one of the following: AKI, cardiac arrhythmia, or some of the sequelae of hypocalcemia like seizure or tetany. This table shows that the risk of TLS is higher with certain malignancies, particularly hematologic malignancies like lymphomas and leukemias. And it's less common with solid tumors, but there is a higher risk with some of the certain types like small cell lung cancer or treated breast cancer. There are also a number of targeted therapies that are so you can see from this table there are a number of others that are implicated, like the anti-CD20 antibody obinutuzumab, CD kinase inhibitors, and CAR T therapies. Given that the risk of TLS is high in patients getting venetoclax, it's actually recommended that the dose be ramped up slowly and in a stepwise fashion. And in particularly high-risk patients, the 20 milligram and 50 milligram doses should actually be given in the hospital with hydration and potentially even nephrology consultation. What about TLS prevention in general? So all patients should get fluid, regardless of their risk. And those who are at moderate to higher risk, you also want to give allopurinol or febuxostat. And then in particularly high-risk patients, you consider rasburicase. In those with established TLS, you need very close monitoring, maybe even in the ICU, fluids and rasburicase. What about urinary alkalinization? This has actually fallen out of favor. And the reason for that is even though it helps lead to the conversion of uric acid into a more soluble metabolite that can be excreted into the urine, it can actually promote further precipitation of calcium and phosphorus and lead to more tubular obstruction. And so that's why we don't do it anymore. You're probably familiar with the mechanism of action of a lot of the hypouricemic agents that we give. Allopurinol importantly decreases uric acid production, but does not clear existing uric acid. Rasburicase can control uric acid levels really rapidly, and the way that this works is it converts uric acid to allantoin, which is a more soluble metabolite. A couple of important things to remember about rasburicase, though, is there's actually very limited data on whether rasburicase improves renal outcomes in patients with established TLS. It's contraindicated in patients with G6PD deficiency because it can cause methemoglobinemia, and it's also very expensive and not always widely available. So in terms of the treatment of established TLS, so I mentioned that intensive supportive care is important, continuous cardiac monitoring and frequent monitoring of electrolytes and labs, reducing dietary phosphorus and K in the diet, and then rasburicase, as we mentioned earlier. Now, renal replacement therapy and the timing of institution, this is something that comes up quite frequently, and there's actually very little data on it. But anecdotally, a lot of us feel that early initiation of RT may be of benefit in these patients because it helps increase the clearance of potassium, phosphorus, uric acid, and it also helps correct acidosis and hypocalcemia. So my goal with these three cases, in summary, was just to show you that AKI in the cancer patient is common. It's varied in terms of its causes and presentations. It can be related to the treatment. It can be related to the cancer, as in the case of amyloidosis, or it can be related to both, like the TLS case. So we just barely scratched the surface in terms of causes of AKI. Excuse me, and there's so much more we're learning about onconephrology every day. So I want to thank you for listening, and I want to encourage you to join the American Society of Onconephrology if you haven't yet. Thank you very much.
So I think we have some time for discussion, and maybe we could take it.
Thank you. I think, first of all, I'd like to thank all of us. Would like to thank Dr. Umesh Khanna for this conversation on onconephrology, and I think most of us sitting here who are dealing with this kind of patients realize that we need to learn more, because there are sessions after this on pathology of malignancy diseases and MGRS. So we'll just discuss a few things about one that was taken care is the immune checkpoint inhibitors and acute kidney injury. We have actually reviewed our data on 1,000 patients in our hospital. It's not as important or as significant and noted worldwide. We're looking at 25 out of 1,000 patients actually had some form of renal involvement. That included proteinuria and acute kidney injury. So I would like to know if there is anybody who has an experience similar or otherwise. And second area which we always feel is the AKI or progressive kidney disease. We see with our patients who have undergone a stem cell transplantation. I don't know, I am privileged in a hospital which has a very big oncology department, and every day we see transplants done outside in Delhi coming with progressive renal failure. And the question arises whether it is the treatment or the initial disease which caused. Like I have a patient yesterday with AL amyloidosis with creatine 5, with a transplant doing very well. There is no problem with his light chains, his monoclonal proteins. But creatinine just went on. Whereas pre-transplant, his creatinine was 2, which came down to 1. So I leave it to the chair and others to let us know how do they face these drugs and issues with onconephrology.
In addition to the conventional chemotherapeutic agents that we all know and the AKI associated, there has been a lot of talk in the literature, of course, about immune checkpoint inhibitors, and as more and more targeted therapies come in, I think we are going to face this problem. But the issue is, as Urmila mentioned, that the prevalence of renal-related problems with these group of drugs is less. Probably we aren't biopsying enough, or maybe that's the reason, because in our country, how cancer is looked upon is entirely different. Though we have now targeted therapies and longevity is definitely better with cancer. But then unless there's some very, very specific issues or the patient is critically ill, the oncologist does not really refer this patient to us, and we would also take a more sympathetic view and probably not biopsy these patients. And that's the reason why we are not seeing this in large numbers, as you mentioned.
Yeah, I think we are not seeing because we aren't probably, our antennas are not up to pick up these onconephrology related issues.
There are 3 papers from India on this, sir.
Yeah, I agree.
And they did, and I do agree, because they don't biopsy. Like, the reason what we see in India, which is being done, we had a patient on daratinib, 7 grams proteinuria. The oncologist just withdrew the drug. The issue with pembrolizumab and nivolumab, they just withdraw the drug. Whereas I think in the rest of the world, they continue it despite a little bit of kidney involvement here and there.
Right. And the other thing is there are a lot of other areas like hypertension, electrolyte abnormalities, which we do not specifically pinpoint it towards the reason being the onconephrology drugs.
I would beg to differ here. Our oncologists are very proactive, and they want to refer the patients much earlier, thinking that there will be problem contemplated, and at creatinine of 1.1 also and urine protein of trace or 1+ also, they would refer the patients because they think they want to continue with the therapy, and for renal cause it should not be discontinued. So if we can do something proactively, and we do get involved early, we make sure that the diuretics are at their minimum, dehydration is not an issue which is causing the AKI, and of course prevention of tumor lysis and all those things are helping make the therapy lasting and more effective.
So Bhavesh, I think the AKI gets picked up much earlier, but the other issues of onconephrology which a nephrologist should pick up are probably not.
Electrolytes with TPIs are not picked up.
That's what I'm saying. Electrolyte imbalance, maybe hypertension.
They're not picked
Acidosis.
Yeah,
Acidosis also.
I think
Yes.
the question would be when to biopsy some of these patients. We are quite hesitant to biopsy these patients. Many of them would have even TMAs, So to pick up these patients and whether even plasmapheresis helps in any of these cases. And some of these like cisplatinum, methotrexate, some of them can go into CKD in spite of our best efforts also. So
they use pemetrexed now very frequently, and it is notorious to progress to CKD if not taken care. So my oncologists ourselves tell us.
Hello. Yeah. Yes, ma'am. So I have, in oncology, we cannot take the decision of that the problem is caused by drug, you take out the drug. This is not that easy. But there are few things, as in for the management-wise, we add ARBs, ACE inhibitors for proteinuria. But if we don't have that, the SGLT2, which we routinely use, there is a dilemma whether to use it in an oncology patient or not to use. So what's your take on that? And second thing is, any experience with bevacizumab related biopsies? Because I have a couple of patients and I'm in dilemma what to do with them, because theoretically they increases the risk and I don't have personal experience.
We had one TMA with bevacizumab. One TMA we saw, and we have not done. The proteinuria which happens with these NIBs or other drugs,
We can continue the drug
But
with
we
it
did-
till the nephrotic range.
Actually, we did continue.
Huh.
But the
So that is what.
proteinuria did not come down. Then the oncologist got another investigational drug and removed daratinib. And you'll be surprised, the proteinuria came down to almost normal. By just, it was like, so there are drugs which are causing various other effects which we are missing. It's just not as simple as with the conventional platinums and methotrexate. Things are very different. So we need to actually work together and find
So
out.
did you use SGLT2 inhibitors in them?
We did ACE inhibitors, ARBs. We did not use SGLT2.
Unfortunately, my
I have
patient, I can't use that.
I have been using and being more cautious about the hydration part and the acidosis part, and I have got a fair response, though select a few patients, but I have been able to let them continue with bevacizumab
And
with SGLT2 inhibitors on board.
any bevacizumab related bleedings, histories and anything? Okay, thank you.
Excuse me, sir, I did not realize as to why would we think differently for using an SGLT2 in this case. I mean, why are we worried about SGLT2 in onconephrology?
Because in some malignancies they say that SGLT2 increases the progression of malignancy. So it's been dilemma. It's been in dilemma. As in the literature I had gone through, that's what they says. The in pancreatic malignancy, in bladder malignancies do increases the risk of progression. In few there are other reports also that it in fact slows down the progression. So I don't know.
That was a literature which was long time back when it came with canagliflozin with bladder cancer. That is not there anymore. We were part of the earlier studies. It was never there. I don't know, Dr. Vivekanand Jha may see, but those cancer concerns of bladder and all is, I think, not there.
Bladder, pancreas.
There was some concern raised about it, but I don't think it's been really proved.
I think we're going to now move to the next session. Thank you very much.